Hello folks, my name is Jeff Staudinger. I'm the director of the MSSU-KCU Research Consortium. I'm also professor and chair of the Basic Science Division at Kansas City University, coming to you from the campus of Missouri Southern State University. I'm here to describe ongoing IRB-approved MKRC research projects. Here is a brief outline of today's talk. I will provide you with an introduction to the MSSU-KCU Research Consortium, followed by the what, where, why, and when, as well as a map to the crime lab at MSSU at the Mills-Anderson Criminal Justice Center, and some MKRC general information. That part of the talk will be followed by Dr. Arntz describing his Freeman Hospital sepsis research projects put together for KCU Student Doctors. That will be followed by Student Doctors Phil Vayner and Elijah Elliott describing a study that I've put together called An Interdisciplinary Approach to Improving Clinical Outcomes in Patients with Opioid Use Disorder. So personally, having become aware of the need for additional research opportunities for Kansas City University student doctors, one of the first things I did was go about obtaining a Canvas learning module for the Basic Science Department and create the MSSU-KCU Research Consortium, or MKRC for short. And on this Canvas learning module, there's a number of links. You can learn about us. Student doctors can also learn about ongoing IRB-approved studies. We host a Faculty Friday seminar series. This is bi-weekly at 3 p.m. this semester. You're all welcome to join. Student-led journal clubs, alternating weeks with the Faculty Friday seminar series. So bi-weekly students will present journal articles or case studies of interest. MKRC breaking news. There's a map to the so-called crime lab. We're on the campus of MSSU in what used to be the state crime lab in the criminal justice. That's the Mills-Anderson Criminal Justice Building. KCU Research Spotlight highlights KCU faculty and their research interests systematically. COVID-19 resource document is an awesome piece of work by recently graduated student doctors. It's one of the more amazing broad review documents I've ever seen. Certain links for KCU faculty, certain links for KCU students, and a link to the KCU newly formed research club in Joplin. A brief word about this newly formed research club in Joplin would be that it's one of the larger clubs on the Joplin Kansas City University campus, with boasting 90 plus participants, and this speaks to the hunger that student doctors have for research endeavors to drive their careers forward after they graduate. So if you click on the About Us link, a page comes up describing MKRC basic researcher profiles, the what, why, where, when, ongoing IRB approved studies, a map to the lab, student application, general information, and other various and sundry things, to include recent publications, interviews, and a description of other activities housed within the MKRC. At this site, you can download documents that describe in more detail what, where, why, and when, what it means to participate in MKRC research activities for KCU Comm students. As far as where the lab is located, here's a Missouri Southern campus map. Over along here is Range Line. This is Newman Road, and the Mills-Anderson Public Safety Center is right here. If you follow the purple arrows, the entry to the lab is in the back. Again, this is where the Missouri State Crime Lab was housed for many years. With respect to MKRC general information, for example, the MSSU-KCU partnership offers clinical and basic research opportunities for KCU Joplin students. You might be interested to know that students began research studies through this new partnership in the spring of 2019. This became possible because in 2018, MSSU and KCU formalized a Memorandum of Understanding that gave rise to the MKRC. As a mission statement for the BMRL, is as follows. The anchoring location for the MSSU-KCU Research Consortium, the BMRL supports basic and clinical research that investigates complementary and integrative healthcare approaches. A vision statement for the MKRC could be, by blending studies that use conventional biochemical, sociological, osteopathic, and mind-body intervention principles together in an interdisciplinary way, the MKRC is uniquely positioned to succeed in improving the well-being of the people in the 4 states region. Thus, the overall goals of the MKRC are to engage MSSU and KCU students in interdisciplinary clinical and basic research opportunities for learning, to improve the health of the people in the Joplin, Missouri community, and to provide evidence-based osteopathic medicine through a team-based healthcare delivery strategy. So the BMRL boasts approximately 2,000 square feet of laboratory space, to include biosafety level 2 facilities such as an autoclave and tissue culture hood. We use immortalized cell lines and primary cell types. We have real-time quantitative PCR machines. For example, this machine could be used to detect COVID, for example. Moreover, we have a really nice biotech synergy multimodal plate reader, dual microinjection systems, allowing us to measure cortisol and other markers of stress in both serum and saliva. We also have an iBright FL1000 Western blot and gel documentation system. Thus, you can see the biomedical research laboratory we've built in the former crime lab of the state of Missouri in the city of Joplin on the campus of Missouri Southern State University in the Mills-Anderson Criminal Justice Building has given us the capability to provide biomedical research support for our clinical studies. Going back to the home page of the MKRC Canvas, if one clicks on ongoing IRB approved studies, you can see the MKRC in Joplin has 4 ongoing IRB approved studies to include OMT and opioid use disorder. This is a collaboration between myself and Dr. Nauman Ashraf, director of the medication assisted therapy of the opioid-based opioid treatment program at the Ozark Center, which is the mental health division of Freeman Health Systems. Doctors Arntz and myself had another study entitled Methamphetamine and the Oral Microbiome with an eye towards the dental school coming to Joplin in the future. Doctors Rogers and McNabb have exercise and type 2 diabetic patients. And lastly, OMT to decrease stress, anxiety, and depression in first responders is a study driven by Drs. Creamer and Zaremski. And next, I'd like to pass the baton to Dr. Arntz, who's going to describe a clinical IRB approved study entitled the Freeman Hospital Sepsis Project.
Hello and welcome to the Sepsis Research Project Update. I'm Bob Arntz and I'm an ER physician and a full-time faculty member at KCU in Joplin, Missouri. I'm also an attending at the Freeman Residency for Emergency Medicine there in Joplin as well. And I'm excited today to talk to you about the sepsis research I'm doing through KCU at Freeman Hospital. In my opinion, the need for clinical research in medical school has never been greater. First, the profession needs it. As we move towards evidence-based practice, it's going to be more and more important for us to do research to identify what best practice is. Next, students need it. I'm not sure if you're aware, but there is a movement amongst medical schools across the nation, and this is also true at KCU, that classes are going to pass-fail. And also, along with this, board exams are now moving to pass-fail. So COMLEX 1 and the USMLE Step 1 are now both pass-fail exams. Whether you agree with this move or not, it removes some of the things that our students have used in the past to distinguish themselves, and therefore extracurricular activities, including research, are going to be increasingly important to help them get into competitive residencies. The challenges to conducting clinical research with medical students are significant. First, students have very little time for research. There's about a 3-month window at the end of their first year, and then about a 1-month elective that they can choose to take either in the 3rd or 4th year in order to complete research. Next, most of our students are novice researchers. They're going to need mentoring and development of research skills in order to conduct clinical research. And then finally, there are a lot of logistical hurdles to overcome in order to conduct clinical research with medical students. So here's the aha moment in how the sepsis research project was born. I had been thinking about how students needed research and that they don't have a lot of time to do it. And in my former life, prior to coming to KCU, I was an ER physician, but I also founded and was the CEO of a physician staffing company. And we staffed ERs in the 4-state area. And during that experience, I found that we ended up putting a lot of money at risk to hospitals based on performance and achievement of benchmarks. So I knew that hospitals collected a ton of data that they had to report to the government that affected their Medicare modifier and all different types of reimbursement. So my ideal was to create a research opportunity for multiple students where we would use data that had already been collected by the hospital, so our students didn't have to go searching for it, and that we would streamline all aspects of the research experience so the students could get the research done in the allotted time window that they had available to them. So my aha moment led to the development of a project team by which clinical research could be done and facilitated for a number of students at the same time. And initially I reached out to Scott Goad, Dr. Scott Goad. He's a PharmD and the Director of Residency Research for the Pharmacy Program at Freeman. And then I knew I needed somebody that was great with data, so I reached out to Greg Stahl, and he is involved in quality at Freeman and is a wizard with data collection and analysis. I then reached out to Shelley Sloan here at KCU, and she agreed to be the project manager, and she facilitates all day-to-day functions with the project and acts as a mentor for our students and just is instrumental in day-to-day function. And then lastly, but certainly not least, I reached out to Dr. Carrie Johnson, who is the chairman of the math department at Missouri Southern State University and a whiz with statistical analysis. So he's our statistician and just fantastic. So this is the team, and we are in the process of identifying best practice to facilitate research here at KCU for our students. So we now had our plan in place, we had our mechanism in place, but what are we going to study? And we landed on sepsis. And so why sepsis, you ask? Well, there are a lot of reasons, which I'll be brief, but we'll go through. So sepsis is a huge issue. In the United States, there's close to 1 million sepsis cases that are admitted annually. And this number of cases rises each year. Sepsis accounts for more than 50% of all hospital deaths. And there is a disproportionately high burden in terms of hospital utilization for patients with sepsis. For example, the average length of stay for a septic patient in the U.S. is 75% greater than that for most other conditions. The cost of sepsis management in the United States ranks among the highest for all admissions in the U.S. Currently, the cost is over $25 billion annually. And then lastly, I'm an ER physician, I still practice, and I had some concerns and still do have some concerns about how we take care of septic patients. So I'm going to take a slide here and express my concern as to how we manage sepsis in the United States. So most of how we manage sepsis in the United States comes out of the Surviving Sepsis campaign, which started back in 2002. And subsequently recommendations out of there have dictated how sepsis has been managed. Now, it's interesting to note that that program was started by Eli Lilly, who at the time was trying to find a way to market a drug that they were using to treat sepsis, which has since gone by the wayside. But the recommendations that came out of that Surviving Sepsis campaign and continue to come out of the Surviving Sepsis campaign impact how we manage sepsis. So there is a treatment bundle which comes out of the Surviving Sepsis campaign recommendations that has been incorporated into a core quality measure by the Centers for Medicare and Medicaid Services. So this is a big deal because basically it's a government mandate on how sepsis will be managed, and it's also established standard of care. So from a medical legal perspective and from a financial perspective, because this is tied to pay for performance, both for the hospital and for physicians, you're kind of mandated to manage sepsis this way. And you know, when you're a hammer, everything's a nail, but not all patients benefit from a universal management plan for sepsis, and I'll get into detail with that. So for just sepsis in general, within 3 hours, they want a serum lactate measured, blood cultures done prior to antibiotic administration and antibiotics administered. And then at 6 hours, you're to repeat a serum lactate. And for patients that have septic shock, within 3 hours, they want a lactate measured, blood cultures, antibiotics, and then they want 30 mLs per kilo of fluids, okay, within the first 3 hours of the patient presenting with sepsis. And then at 6 hours, you're to repeat tissue, perfusion, and volume assessment. And then if they're still in problems regarding their perfusion, you start vasopressors. So why do I have an issue with this? Well, if you have somebody that has a large BMI, i.e. they're overweight, you might give them more fluids than they would actually need. Also take into account patients who had renal failure or patients that have CHF with low ejection fractions. You know, if you give somebody 3 liters of fluid and their ejection fraction's 15%, you might fix their sepsis, but you might kill them in the process. So, you know, obviously the concern is that one size does not fit all, and this is probably good for the majority of patients, but certainly not good for certain subsets of patients. So based on the information that I shared in the previous 2 slides, my team chose to focus first on sepsis. And so here is our sepsis research site. Our students both on Joplin and Kansas City campus can access this, and all the onboarding information they need and all the steps they need to complete in order to participate in sepsis research with us is contained within this site. Once again, the purpose of our project was twofold. One, to do research in sepsis, but 2, to really build a mechanism by which further clinical research could be done on a large scale. And so this is just a timeline that we established for our students, and this is through trial and error, but essentially in fall, they're still in classwork and they maybe familiarize themselves with some of the onboarding material. And then in the winter, they start doing the applications, and then spring, they go ahead and start their lit review and submit a formal request for research to KCU. And then in the summer, they complete their lit review. They get their results from Freeman on whatever topic they're researching. They do the bulk of their writing, and then they choose a target journal for publication. Typically, poster and publication are completed in the 2nd year. And then 3rd and 4th year students also have an opportunity to do a research rotation. And again, that's much more condensed time. But again, we're trying to do 2 things here. One, sepsis research, but also to establish a process to get clinical research done here at KCU. The project timeline, we obtained approval in August of 2020. And this is kind of currently where we're at with things in terms of onboarding students and having research currently being conducted and following through the process. So we have some students that are onboarding, other students that are in the midst of their project, and some that are at the end of their projects. Currently, we have 15 different research projects ongoing underneath our single sepsis research IRB. The first one, we're looking at the bundle that we mentioned previously in regards to the treatment of sepsis and trying to decide if that adherence to the bundle is beneficial to patients or not. I've got 4 students working on this, and we anticipate a paper and a poster out of that. Next, we're looking at race, gender, age, COPD, CHF and hypertension, diabetes, hyperlipidemia, coronary disease, in terms of atherosclerotic disease, glucocorticoid use, obesity, admission source, like did they come in outpatient or were they transferred from another facility, et cetera, and then renal failure, lactic acid levels, and hypothyroidism. So all of these are separate topics we're looking at under the umbrella of sepsis, and we have various numbers of students working on each of those and anticipate posters on all of them and papers on some of them. So I would like to emphasize this is not ready for prime time, but some of the preliminary results we've seen in our studies, factors that don't appear to affect mortality rate would include bundle compliance, gender, heart disease, presence of hyperlipidemia, presence of type 2 diabetes, and presence of hyperthyroidism. Factors that seem to affect mortality rate include COPD, the presence of shock with sepsis, the presence of acute kidney failure with sepsis, elevated lactic acid levels in sepsis, and elevated BMI. Again, we're not sure yet to say that these are cause and effect relationships. We have not run statistical analysis. So this is, again, data that is not ready for prime time and nothing that I would base any clinical practice decisions on. But it's interesting nonetheless, and stay tuned. We'll be back in a year to let you know what plays out after we look at the statistical analysis. As I wrap up this update on the sepsis research project, I want to emphasize again, the project is in its infancy. Again, our preliminary data is just that, preliminary data. I wouldn't base any clinical decisions on what we have sorted out to this point. But I am excited about the progress we've made thus far and the fact that we've had, to this point, 45 students engaged. Again, thank you very much for your time. I'd be happy to answer any questions you might have regarding the sepsis research project or sepsis in general.
Hello, everyone. I am student Dr. Elijah Elliott.
I'm student Dr. Phil Vayner.
And today we're going to present our project called an interdisciplinary approach to improving clinical outcomes in patients with opioid use disorder. To begin, I'd like to show you how to navigate the Canvas page. So first you'll go to the MKRC Canvas page, and then you'll click on the ongoing IRB approved studies. That'll take you to all of the IRB approved studies that the MKRC has going on. And next, you'll click on the OMT and opioid use disorder, and that'll bring you to a page that has all of the documents and all of the videos that we'll be talking about today, as well as a broad outline of what's going on. So the rest of the page looks like this, and we have all of our information here available for download that you can look at anytime you'd like.
Okay, so to begin, it's important to define opioid use disorder, as the aims of our study, which we will speak on in depth in the coming slides, directly focus on integrating osteopathic principles and OMT into helping treat opioid use disorder. So the Diagnostic and Statistical Manual of Mental Disorders, also known as the DSM-5, defines opioid use disorder as a problematic pattern of opioid use leading to clinically significant impairment or distress. Likewise, the DSM-5 lists 11 criteria that when used in diagnosis is required that patients demonstrate at least 2 of the 11 criteria for diagnoses. Some potential examples include 1, when there's constant opioid use, when constant opioid use causes users difficulty in maintaining and fulfilling obligations at work, school, or at home. Another example would be when opioid users demonstrate a persistent desire to cut down or control their opioid use, but are unable to. And another example would be when users develop a tolerance and need markedly increased amounts to achieve their desired effects. And these are just 3 of the 11 examples needed. Well, they need 2 of this is 3 examples of the 11. However, only 2 of the 11 are needed for diagnosing opioid use disorder. So now I want to talk a little bit about what is fueling this need to find novel and effective treatment regimens in dealing with opioid use disorder. So as we can see on this graph, since 1999, the opioid epidemic has progressed in 3 distinct waves. Wave 1 was triggered by the increase in opioid prescriptions in the late 1990s as pain management moved to the forefront of patient care. Meanwhile, pharmaceutical companies were promoting all the great benefits opioids can provide without highlighting their extreme likelihood for abuse and addiction. Then around 2010, we started seeing an increase in overdose deaths caused by heroin. The reasons for this increase are multifactorial. However, according to the DEA, a key driver was increased demand for opiates was being met by a relatively low-cost heroin being shipped in from Mexico and Colombia at a significantly higher rate than ever before. Lastly, around 2013, we started seeing a significant increase in overdose deaths caused by synthetic opioids like fentanyl. Like with the rise in heroin, strong demand drove suppliers to cut heroin with additional opiates to increase its potency and decrease its cost. And as you can see, this increase in potency corresponds with a staggering rise in opioid overdose deaths since 2013. And on the slide, I also have listed some pretty triggering facts regarding the opioid epidemic. Things that since 1999, there's been a 400% increase in drug overdoses related to opiates. Currently, 70% of all drug overdose deaths are caused by opiates. And even more recently, from 2018 to 2019, the rate of opioid-involved death has increased by 6%. And to bring matters a little closer to home, here on this graph, we see the same national trend occurring in Missouri since 2013. Opioid overdoses are rising, and synthetic opiates are the leading driver of our current 3rd wave here in Missouri. Then on the right, he will show things from a more monetary health policy standpoint. On this pie chart, we're showing just how impactful opioid-related emergency department visits are towards total healthcare spending in Missouri. So finding novel treatments to handle our opioid epidemic will not only save our healthcare budget significant amounts of money, but more importantly, it would limit these unnecessary deaths we're seeing in our population. So this now begs the question, can OMT help in combating opioid use disorder? To help answer this question, we're honored to partner with the Ozark Center's New Direction Suboxone Clinic, a clinic owned by the Freeman Health Systems that provide medication-assisted treatment, also known as MAT, services alongside weekly counseling to individuals suffering from opioid use disorder. Our research design is as follows. We will have 5 experimental groups. The first group would be a group only receiving the standard of care. The second group will be receiving manipulative therapy plus education. The third group will only be provided OMT. The fourth group will only be provided education. And the fifth group will receive a sham OMT. And in future slides, we will cover in detail what all these experimental groups consist of. The study will be conducted in 3 8-week trials. Each trial will consist of 4 participants per experimental group, and each group will have a male and female cohort. Per trial, we will have a total of 40 participants, 20 male, 20 female, and the total number of participants in the study will end up being 120. Here are some eligibility and inclusion criteria for the study. The participants have to be at least 18 years old, but no older than 65. They have to be enrolled patients in the New Direction Suboxone Clinic, and they need to be experiencing side effects from Suboxone, such as ongoing cravings for opioids or chronic lower back pain. To collect data from our participants, we intend on measuring serum salivary cortisol at the beginning and end of each trial. The steps for collecting salivary cortisol are relatively simple and consists of the following. First, right as the participant wakes up, they will place a salivette, just like a little absorbent pad, in their mouth for about 30 seconds. Then they'll take the pad out, put it in a container to be stored and delivered later. 30 minutes after the first collection, they'll do this again. Then 1 hour after their first collection, they'll do it a third time. Then lastly, at the end of the day, right before going to bed, they'll collect their fourth salivette salivary cortisol specimen. And again, this is being done at week 1 at the beginning of the trial, and then week 8 at the very end of the trial. Now, a good question to be asking is, why cortisol? Well, before I get into that, I'd like to give a quick summary of what exactly cortisol is. Cortisol is a glucocorticoid produced by the hypothalamic pituitary axis. It shows increased release in response to psychosocial and biological stress. For example, things like emotion, pain, or vigorous physical activity are all things that in theory would increase cortisol levels. Also, this last slide may have made you wonder why the collection procedure had such a unique schedule, that being the 4 collections in a day. The reason being is that cortisol is released on a diurnal pattern, as you can see on this graph. Right around 8 a.m., we see a very high peak for our normal diurnal rhythm. That corresponds to cortisol being at its highest right around the time of any individual wakes up. Then throughout the day, it decreases until they're asleep. And then we begin to see a gradual rise up until they wake up in the morning. Now, to talk about why we're going to choose cortisol as our biomarker for this study is that cortisol has been shown to be an excellent biological marker for uncontrolled pain. Another thing that's special about salivary cortisol is that it shows a very consistent direct relationship with serum cortisol levels. So unlike other biomarkers, choosing cortisol eliminates the need for venipuncture, which makes matters a lot easier for our participants. It's a lot more difficult to ask patients for their blood as opposed to their saliva. However, there are disadvantages to cortisol. One being that those serum biomarkers that are exclusively in serum, like IL-6, IL-2, TNF-alpha, have been shown to be more significant biomarkers for inflammation, pain, and other things that would be directly associated with opioid use disorder. Another issue with cortisol is that although we do not have to perform venipuncture, the procedure of the 4 salivettes in a day is also relatively difficult to obtain compliance from our participants because it has to be done very accurately. And to obtain statistically significant results, we would want at least 3 cortisol measurements in week 1 as well as in week 8. However, we've chosen to only collect 1 at the beginning of the study and 1 at the end of the study, just to keep the requirements easier on our participants.
Now I want to talk about the OMT protocol that we're going to be utilizing in our study. So first, I want to remind everyone of the experimental groups. So first we have the standard of care, and then we have a group receiving only the curriculum. And then we also have a group only receiving OMT. And then we have a group receiving the sham OMT. And then finally, we have a group that's receiving both OMT and the curriculum. And it's important to note here that every group is going to receive the same standard of care. The control group is the only group that's not receiving additional treatment. So really quickly, I'll just overview what OMT is. And that stands for osteopathic manipulative treatment or therapy. And what it is it utilizes manipulations of different tissues and encourages healing. So things like bone, lymph, and soft tissue can be manipulated externally by a trained individual to encourage, again, healing. The techniques that we're using are rib raising, sacral rocking, suboccipital inhibition, and compression of the fourth ventricle. And so what we really want to do is encourage autonomic balance by using these techniques. So, for example, rib raising will decrease a sympathetic response. Sacral rocking will increase parasympathetic response. Suboccipital inhibition and compression of the fourth ventricle both increase parasympathetic responses and can also treat neck pain and headache treatment. And that will come into importance later on, and I'll talk about that. Here's kind of a visualization of what we're doing with these different techniques. So for rib raising, we're going to reach around and grab those ribs, each individual rib, and encourage extension. For sacral rocking, we're going to place our hands on the sacrum and encourage with respiratory assist and move them through which barrier they have. For occipital inhibition, we're going to place our hands underneath the nuchal line there that I have labeled on that image. And for CV4, we're going to go to the pedicles of the occiput and kind of encourage a balance point there. So again, these are just really basic outlines of the different treatment. And by no means is this comprehensive. For our sham OMT group, this is going to be done by individuals that are untrained in OMT. So they are untrained individuals. And so broadly speaking, the treatment is going to include something like getting them into the starting position and just holding it. There's going to be no activating forces. Then we're going to return them to the starting position, allow them to rest, and then repeat for all those 4 techniques. So again, we're going to outline what Suboxone is really quickly, and it is a combination drug of both buprenorphine and naloxone. So if you remember, buprenorphine is a mu receptor partial agonist, so it's going to elicit a response similar to something like methadone, but not nearly to the same efficacy that methadone will. And so that's important because it helps with withdrawal symptoms. However, patients can abuse buprenorphine if they don't take it sublingually. Maybe they take too much, or maybe they will crush it up and use it in a different manner than sublingually. And so that's where naloxone comes in. And naloxone is a very strong antagonist, and it will immediately shut down any binding to those mu receptors. And that's advantageous if someone is abusing Suboxone, because it allows for stoppage of misuse. It doesn't allow them to overdose on buprenorphine, essentially. So again, it's important that buprenorphine is active sublingually and naloxone is not. So why Suboxone and OMT? Well, many of the side effects of Suboxone include things like chills, headaches, pain, withdrawal, constipation, sweating, insomnia. And so the ones I've highlighted are directly treated by the 4 treatments that we're utilizing in the OMT protocol. There's also a lack of literature of opioid management therapy in OMT. And so this study would kind of be cutting edge by combining the 2, looking to see how they interplay with each other. And it also allows a novel approach to managing Suboxone side effects, kind of like what I talked about earlier. Okay, for the curriculum. To give an overview of the curriculum, we have 8 weeks of 8 week of curriculum, and it's designed to inform participants about, broadly speaking, their disorder, how to treat it and its medication side effects, how to manage cravings, side effects, and relapse fear, and also nutritional and alternative treatment education. So things like OMT will be included in that education, as well as things like yoga and meditation. So a lot of student doctors have recorded videos to provide education on these topics. And so that includes things like salivate use instructions and also the informed consent. It's also important that we talk about each video, that those student doctors have recorded, and that will be played each week as they arrive to receive their standard of care treatment. So here are the each 8 weeks outlined in order. First, we're going to talk about the study purpose and give kind of an introductory course on the alternative therapies like OMT and yoga. Next, we'll talk about opioid use disorders. And then the next week, nutrition, how nutrition will affect your side effects and your cravings and things like that. Recreational activities and their effect on opioid use disorder, how to find a hobby, how to find a group of people going through the same thing you are. Relapse fear responses, how to deal with relapse fear. Aspirations for the future. What do you want to do after this study? Where do you see yourself going after this study in terms of your addiction? There's Narcan training, and Narcan is a nasal spray that is used in emergency situations of overdose on narcotics. And we also have our last week, the different types of medication that's used in opioid use disorder. And that will be presented by a pharmacist. So Dr. Staudinger YouTube channel hosts all of those curriculum, and I've included a link in this PowerPoint of the 10 different student doctors that have contributed. So here's what that YouTube playlist looks like. It's also important to mention that there is a PDF on the Canvas page that outlines each video separately. So next, I want to talk about the 2 different types of scales that we're including in this study. And the first is the Montgomery and Asberg Depression Rating Scale, or the MADRS. So to overview this scale, it's to assess patient depression severity. And again, it was kind of utilized, and we'll talk about this in a minute, the effectiveness of antidepressants. So patients will start antidepressants after receiving a rating on this scale. And then throughout the weeks, they will be using the scale again to assess how effective those medications are. So clinicians will also assess this via interview. So it's important to mention that this can only be done by a physician. And so there's 10 different assessments in the MADRS, and each are given a rating 0 through 6. Again, 6 is the most severe, 0 would be it's absent. So real quick history, it was designed in 1972 by 2 different British and Swedish researchers, S.A. Montgomery and M. Asberg. And again, the goal was to create an unbiased test to use with the Hamilton Rating Scale for depression. And they wanted it to be more specific for antidepressant effectiveness. And it's important to note that both tests show a great deal of correlation when you compare them. So here are the different attributes to the scale. We have apparent sadness, reported sadness, inattention, reduced sleep, reduced appetite, concentration difficulties, lassitude, inability to feel, pessimistic thoughts, and suicidal thoughts. So if we look at the different scores, the clinician will sum the rating after the interview. And a rating of 0 to 6 will indicate that there's no depression. 7 through 19 will mean that there's mild depression. 20 through 34 is moderate. And 35 or greater, we have a severe depression. But if there's a 10 on every score, obviously that will show you it is a very severe depression with a rating of 60. So next we'll talk about the second scale that we'll be using in this study, the Hamilton Anxiety Rating Scale. To overview this one, it was created by Max R. Hamilton in 1959, and it's to be used in patients that are already diagnosed with anxiety. And again, it's to kind of quantify how severe a person's anxiety is. It puts it on a scale. And this is also done by physician interview. So here is literally the page that's on Canvas. I just copy and pasted the image there. This is the scale that we'll be using. So again, we're looking at 14 different attributes ranging from anxious mood, tension, fears, insomnia, all the way through symptoms that we see like respiratory symptoms, GI symptoms, GU symptoms, autonomic symptoms, and even their behavior at the interview, how they're acting. Are they straining? Are they tremoring? Or do they just seem tense? And so the clinician, again, will sum all those ratings given, and a 17 or less indicates that there's mild anxiety. 18 to 24 is moderate, and 25 to 30 is severe. So there's some advantages and disadvantages of these different scales. So first we'll talk about the advantages. And a big one is it allows us to quantify severity of depression and anxiety. And that's huge when we're tracking these patients throughout our 8-week course. It also allows a broad coverage of pathological aspects of anxiety and depression. And that's a really big deal too. These are really universally accepted as very good resources in treating depression and anxiety. Some disadvantages are that they must be done by a physician. So we can't have medical students that are a part of our study doing these interviews. It would not be right. It also does not provide complete coverage of all disease symptoms in the Diagnostic and Statistic Manual of Mental Disorders. However, it's argued that these two scales do a really good job of getting as close as possible in a very effective manner.
Hello again. So to begin concluding this presentation, I wanted to really just hit home our aims for this study. So more than anything else, we want to figure out to what extent can osteopathic manipulative therapy be used as an adjunct therapy in treating opioid use disorder. In addition, a few other things we really want to measure and try to gain a greater understanding of is how effective OMT can be used in reducing the traditional adverse events with Suboxone treatment. We touched on this earlier, and we'll touch on it again. The frequency and intensity of headaches are a big, difficult obstacle to overcome for people suffering from opioid use disorder that are being treated with Suboxone. So if we can show that OMT does significantly reduce the frequency and intensity of headaches, we're going to come a long way in helping patients trying to get over their addiction, get over it successfully. Another thing we want to see how effective OMT is in how well to what extent it can reduce the frequency and intensity of opioid cravings. A few other things on top of that we'd like to measure is how effective is salivary cortisol as a biomarker for measuring pain. And lastly, we want to determine if adding OMT in education groups to Suboxone treatment improve depression or anxiety scores over time. Outside of the specific goals and aims of the study, one thing in particular that this study is really does well is that it's integrating so many different regional partners of the Southwestern Missouri community, Joplin community, to help improve health outcomes for everybody all around us. We're partnering with Missouri Southern State University, Kansas City University, the Ozark Center, so the Freeman Health Systems. We're providing clinical and research experience to students at MSSU and KCU. And we're trying to incorporate evidence-based osteopathic medicine into finding new treatments to better our community. And we just wanted to give a big thank you to everyone who helped us get this far with our research and this presentation. So thank you, Dr. Staudinger, Dr. Ostroff, Dr. Carrie Jordan, all of the OMM faculty that are participating in this, all the residents of the Ozark Center, the New Direction Suboxone Clinic and all of their staff, Dr. Rogers and Dr. Creamer, student Dr. Praneeth Padada, student Dr. Parker Howe, and student Dr. Megan Carney.